hematology cases. Unfortunately, the hematology section takes a backseat in clinical teaching in the medical colleges. So it's a very wonderful and welcome step on his behalf to come out with a hematology short certificate course. And thanks, Dr. Daria, for the short and sweet introduction for today's session. And I hope my slides are visible. Just check it out. Just let me know if my slides are visible. Hello, Anandji.
Sir, slide is visual. Sir, put on your sir, yeah.
Okay, so I'll put it on the F5 mode. So now it's visible.
Yes, sir.
Yeah, perfect. So shall we start?
Yes, sir.
Okay. So in the continuum of benign hematology, today we are going to talk on approach to pancytopenia. And as you all know, pancytopenia is a very frequently encountered situation in the usual clinical wards and emergencies and OPDs. So today's presentation objective would be to define pancytopenia, to discuss in short and brief the pathophysiology, to discuss differential diagnosis, to discuss the algorithm of approach to pancytopenia, and hence, and in the last, the diagnostic and the treatment protocol that we have as of now in pancytopenia. So this will cover the next 40 minutes would be focusing on pancytopenia, and I'm sure the students at large would get benefit out of this. So, how do we define pancytopenia? Easily understood. Pan means entire, cytopenia means blood products. So, pancytopenia is a medical condition which is characterized by simultaneous reduction of all three major blood cell types in the peripheral blood, that is the RBC, encountering anemia, the WBC causing leukopenia, and platelets causing thrombocytopenia. So, this condition typically reflects a failure of the bone marrow to produce adequate blood cells, which can result from a variety of underlying diseases or external factors. So, pancytopenia, the whole Pandora's box open by seeing a CBC. Let's go to some basics of what happens in the hematopoiesis. So, hematopoiesis originates in the bone marrow from the pluripotent hematopoietic stem cells, which have the capacity to differentiate in all types of blood cells, and which is tightly regulated by specific cytokines and growth factors that are interleukin 3, which supports proliferation of the early progenitor cells, the granulocyte monocyte granulocyte macrophage colony stimulating factor, which stimulates the production of granulocytes in the macrophages, and the erythropoietin, which promotes red blood cells. Now, any disruption in the hematopoiesis, whether due to a bone marrow failure or to a cytokine deficiency or from an external insult, can impair the production of all blood cell lines and potentially can lead to what we call as pancytopenia. So, a tightly regulated process being disturbed either internally or by externally can lead to pancytopenia, a disturbance in all the three cell lineages. So, what is the status of pancytopenia worldwide? Now, if we consider our own country as developing country, the predominant cause of pancytopenia is nutritional. That is, vitamin B12 deficiency, folate deficiency. Infections become important cause of pancytopenia, such as malaria, HIV, tuberculosis, which specifically disseminated tuberculosis, are frequent contributors. Viral infections can also cause, but of a different type of uh, pancytopenia. Amongst the Western countries, the commonest cause of pancytopenia is malignancy, especially hematological cancers like lymphomas and leukemias. Drug-induced pancytopenia from the chemotherapeutic agents, immunosuppressants, or other medications, which we'll be discussing in few slides from here on, as one of the key causes of pancytopenia in the Western countries. Now, if we consider India, now, India is between the developing countries and the Western countries. Therefore, we are seeing the whole conundrum of causes of pancytopenia. So we are seeing infections, we are seeing nutritional causes, we are simultaneously seeing malignancies and drugs as cause of hematological pancytopenias. Therefore, India and the Indian doctors are at the loggerhead of in the developing and the Western countries, means handling both infections and the drugs. The whole conundrum of pancytopenia is occurring in our country. Now, incidence varies continent to continent and places to place. So, the accurate data regarding this is difficult to decipher, and more studies are required based on the exact causes of pancytopenia. Now, etiology, as I told you, basically, it arises to four main etiologies. Either there is a failure of the bone marrow, or the marrow has been occupied by certain space occupying lesions, or the marrow has been kept ineffective. So there is an ineffective production by the marrow, or the hematopoietic cells have been peripherally destructed. So these are basically the four main etiologies, and one of the one of the commonest cause of pancytopenia in children or in the young people are genetic. And of all the genital causes, congenital causes, there are certain important inherited causes of bone marrow failure, and we'll be discussing in slightly detail as we go ahead. And the first and the foremost thing to be discussed in pancytopenia congenital causes is Fanconi's anemia. Now, Fanconi's anemia is there is a defect in the DNA repair that leads to chromosomal breakage and cross linkages of those broken chromosomes, and hence leads to pancytopenia. The typical feature of pancytopenia in Fanconi's anemia is skeletal abnormalities, especially the skeletal thumb, short stature, and urogenital abnormalities. Now, there is some telomerase diseases which we call telomeropathies, and of the telomeropathies, dyskeratosis congenita is an important cause of congenital causes of pancytopenia, where the telomeres are shortened, and this dyskeratosis congenita presents with a triad of leukoplakia, nail dystrophy, and lacy skin pigmentation, what we call as Caffey or lot spots, and pulmonary fibrosis. We also have mutations in the SBDS genes, and the syndrome of Squashman-Diamond syndrome occurs, and which causes exocrine pancreatic insufficiency apart from pancytopenia. Now, congenital amegakaryocytic thrombocytopenia uh, occurs because of myeloproliferative leukemia virus oncogenes, and there is severe thrombocytopenia with its sequelae. We also have hemophagocytic lymphohistiocytosis, which has defects in the multiple genes of PFR1, UNC13D, and it presents with fever, splenomegaly, hepatitis, and rash. So these are some rare causes of congenital causes of pancytopenia, but Fanconi's anemia and dyskeratosis congenita are very important causes of congenital bone marrow syndrome. And here you see the Fanconi's anemia. A young child, in fact, presents with classical thumb, or what we call skeletal thumb, absent hypoplastic thumb, Caffey lot spots, vitiligo, pancytopenia, bone marrow failures, and abnormal atrophic testis. So this is Fanconi's anemia, and you can recognize these Fanconi anemia children with these features. And you also have dyskeratosis congenita, and you have all sorts of presentation with dyskeratosis congenita apart from pancytopenia. You have alopecia, you have sparse eyebrows and eyelashes, you have esophageal strictures, hyperpigmentation of the skin, telangiectasias, atrophies, hyperpigmentation, cirrhosis, pulmonary fibrosis, keratoderma, and so on and so forth. So these are two very important causes of pancytopenia, which we all must know, and we all must have in our mind while seeing a case of young pancytopenia patients. Now, as far as acquired pancytopenia is concerned, I already discussed marrow hypoplasia or aplasia, marrow infiltration, ineffective hematopoiesis, and peripheral destruction or sequestration can lead to pancytopenia. Now, what are the causes of marrow aplasia? So, this could be idiopathic aplastic anemia, majority of them being unknown, which might be because of some immune mediated reactions where the body attacks its own bone marrow stem cells. Then post viral infections like hepatitis, Epstein-Barr virus, HIV can trigger immune responses and can cause damage to the bone marrow. Drug induced like chloramphenicol, non-steroidal drugs, and chemotherapeutic agents can cause bone marrow aplasia. Marrow infiltrative disorders in adults, the important things are acute leukemia and myelodysplastic syndrome, lymphomas and multiple myelomas, solid tumor metastasis, and myelofibrosis. So these are important causes of marrow infiltration in adults leading to pancytopenia. Peripheral destruction and sequestration can be because of autoimmune hemolytic pancytopenia, splenic sequestration, paroxysmal nocturnal hemoglobinuria, autoimmune diseases like SLE, drugs, leukemia, the HLH, which is hemophagocytic lymphohistiocytosis, and transfusion associated GVHD, which is graft versus host disease, and hence and infections as well. So these are peripheral destructive causes of pancytopenia, and 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 if we go on to further divide uh, pancytopenia based on the bone marrow, we can classify this as pancytopenia with either hypocellular bone marrow or pancytopenia with cellular bone marrow or hypocellular bone marrow with or without pancytopenia. So amongst the pancytopenia with hypocellular bone marrow, I'm just enumerating them. The algorithm will be discussed in slides further to come. So amongst, when you see the bone marrow, and if this bone marrow in pancytopenia patients are hypocellular, the causes could be acquired aplastic anemia, constitutional aplastic anemia, which I just told you, hypocellular myelodysplastic syndrome, rare aleukemic leukemia, some acute lymphoid leukemias, rare lymphomas of bone marrow, and copper deficiency. Now, if we discuss pancytopenia with cellular bone marrow, it could be a primary bone marrow disease or it could be a secondary to systemic diseases. The primary bone marrow diseases are myelodysplastic syndrome, paroxysmal nocturnal hemoglobinuria, myelofibrosis, aleukemic leukemia, myelophthisis, bone marrow lymphoma, or hairy cell leukemia. And secondary causes could be SLE, hypersplenism, B12 deficiency, folate deficiency, copper deficiency, alcohol, HIV, brucellosis, sarcoidosis, tuberculosis, leishmaniasis, sepsis. Now, there could be CBC, which is showing hypocellular, but when you go on to do a bone marrow, CBC may not show bone marrow pancytopenia, but if at all you go on to see the bone marrow, it would be hypocellular. So hypocellular bone marrow with or without pancytopenia, the causes are Q fever, Leguine's disease, anorexia nervosa, and starvation. So based on bone marrow, you have a further different type of classification, and these are three types: pancytopenia with hypocellular bone marrow, pancytopenia with cellular bone marrow, which is further divided into primary and secondary, and pancytopenia, hypocellular bone marrow with or without pancytopenia. So these are bone marrow based classifications. So let's come on to some details of the important causes of pancytopenia, and amongst that, whenever we think of pancytopenia and the cause of pancytopenia, radiation comes in our mind at first. So marrow aplasia is one of the major acute sequelae of radiation. Mind it, it's an acute sequelae, and late effects. Marrow failure is not caused by a late effect of radiation. So marrow failure or marrow aplasia is a major acute sequelae of radiation. And what radiation does? Radiation damages the DNA, and the tissues dependent on active mitosis, which is the hematopoietic stem cells, are particularly susceptible. And interestingly, nuclear accidents do not occur on war only. So it can occur or in the power plant workers only. It can occur in the employees of our hospitals, in the laboratories, in the industries, especially the food sterilization, metal radiography, and we see sometimes incidences of innocent people exposed to stolen, misplaced, or misused sources. We now and then hear in or read in the newspaper that uranium was found on the roadside and picked up by bystanders. So radiation can would be accidental also, and these radiations can cause damages to your DNA and leading to bone marrow failure. Remember, radiation causes acute bone marrow failure. Chronic or late stage bone marrow failure does not occur with radiation late effect as a late effect of radiation. Now, chemicals of all the chemicals, benzene is one of the notorious cause of bone marrow failure. Epidemiological, clinical, and laboratory data link strongly benzene to aplastic anemia, acute leukemia, blood and bone marrow abnormalities. For leukemia, incidence is correlated with cumulative exposure, but susceptibility must be important because only a minority of even heavily exposed workers develop myelotoxicity. Benzene can cause leukemia, but cumulative doses can go on to cause leukemia. Benzene-related blood diseases have declined because benzene use has been declined. But as far as the bone marrow failure is concerned, the association between bone marrow failure and other chemicals other than the benzene is less well substantiated. But yet we must know that benzene is one of the important cause of bone marrow failure. There are multiple drugs which can cause bone marrow failure, and we'll be discussing all these in details now. But let me tell you that uh, association of bone marrow failure with drug is not equal to causation. Like a drug may have been used to treat first symptoms of bone marrow failure, such as antibiotics for fever or a preceding viral illness, or these drugs could provoke a pre-existing disease, like you have used a non-steroidal anti-inflammatory agents, and that causes fatigue. So these drugs can precipitate a bone marrow failure, but direct association or risk estimates are usually lower when determined in population-based study. Even if a drug has 10 to 20-fold increase, yet if you calculate the overall population-based risk factor, the drug-induced cause of bone marrow failure still would be a rare cause. Now, as far as drugs are concerned, we can classify drugs into different categories. Now, drugs or agents that regularly produce bone marrow depression as a major toxicity, agents which can cause frequently but are not inevitably producing bone marrow aplasia, agents or drugs which are associated with aplastic anemia but with a relatively low probability, and agents whose association with aplastic anemia is more tenuous, doubtful. So let's see the drugs or the agents which have the powerful probability of causing bone marrow failure, and these are cytotoxic agents. Now, cytotoxic agents which are used in cancer chemotherapic agents like alkylating agents, antimetabolites, antimitotics, and some antibiotics are regularly causing bone marrow failure. As already discussed, benzene is one agent which is frequently but not inevitably linked with bone marrow aplasia. And major agents which we discuss in our clinical teaching are agents which are associated with aplastic anemia but with a relatively low probability. And these are chloramphenicol, insecticides, antiprotozoals, quinacrines and chloroquines, non-steroidal anti-inflammatory agents, anticonvulsants, heavy metals, sulfonamides, anti-thyroid drugs, anti-diabetic drugs like tolbutamide, the older ones, the chlorpromamide, carbonic anhydrase inhibitors like acetazolamide, antihistaminics like cimetidine, chlorpheniramine, D-penicillamine, estrogen in pregnancy and in high dose in animals. Now, drugs which have a potential, but the exact relationship of drugs and bone marrow failure is not very well established, but they are in doubt. So we call it as tenuous relationship of aplastic anemia with these drugs. And these drugs are antibiotics like streptomycin, tetracycline, methicillin, mebendazole, trimethoprim, sulfamethoxazole, flucytosine. Sedatives and tranquilizers like chlorpromazine, prochlorperazine, piperacetazine, chlordiazepoxide, meprobamate, methylpyrrolone, and then allopurinol, methyl-dopa, quinidine, lithium, guanidine, thiocyanate, carbimazole. These are agents whose association with aplastic anemia is not very strong, but they are under scanners. So if we classify these drugs as far as bone marrow failure is concerned, this is how we can classify agents which have certain, agents which have definite but not always, agents which have low possibility, and agents which are under scanner. So this is how we classify drugs in association with bone marrow failure or pancytopenia. Now, there are certain infections which can cause bone marrow failure, like infectious mononucleosis. Parvovirus B19 is regularly taught as causing bone marrow failure. Rather, they are not causing bone marrow failure, they are causing uh, pure red cell aplasias. There are certain immunological diseases which can lead to bone marrow failure, and of which transfusion associated graft versus host disease is especially after infusion of a non irradiated blood products to an immunodeficient recipient can cause pancytopenia. Aplastic anemia is strongly associated with a rare collagen vascular syndrome called eosinophilic fasciitis, which is characterized by a painful induration of subcutaneous tissues. Thymoma and hypogammaglobulinemia are occasionally associated with aplastic anemia. Pancytopenia with marrow-aplasia can also occur in systemic lupus erythematosus. The unique condition of hepatitis and bone marrow failure has also been observed in almost 5% of patients, which is slightly less frequent. And these are seen in usually young men who have recovered from a bout of liver inflammation 1 to 2 months earlier. And the subsequent pancytopenia in these patients are very severe. The hepatitis usually is non-A, non-B, which is called seronegative hepatitis. Intensive laboratory workup does not give out any conclusive results. Fulminant liver failure in childhood can also follow seronegative hepatitis. So whenever you see a seronegative hepatitis, be careful about the bone marrow failure, which can just follow after 1 to 2 months. Pregnancy also can be one of the causes of aplastic anemia, though rarely. And as the pregnancy resolves after delivery, there is a spontaneous or induced abortion. These bone marrow failure resolve. So these are some of the important causes of acquired bone marrow failure or aplastic anemia or pancytopenia. And one of the very unique thing which needs to be discussed as far as congenital aplastic anemia or pancytopenia is paroxysmal nocturnal hemoglobinuria. Now, this is a genetic disease which is caused by an acquired mutation in the PIG-A gene in the hematopoietic stem cells, and which is this PIG-A mutation probably occurs more commonly in normal individuals. Now, if this PIG-A mutant stem cell proliferates, this results in a clone of progeny which is deficient in the cell surface membrane protein, which is the glycosyl phosphatidyl inositol, and this will further lead to bone marrow failure and go on to certain more complications in times to come. So paroxysmal nocturnal pneumonia, and already discussed in the previous slides the constitutional syndromes of Fanconi's anemia and the ribosomopathies called diamond blackfan anemia and the Schwarzman diamond syndrome. And I also talked about the telomeropathies, where dyskeratosis congenita was one of the important cause of telomeropathies, and these all lead to different types of pancytopenia. Now, how does aplastic anemia present? Usually, the presentation is very innocuous. Patient may come with very vague symptoms, can occur abruptly or insidiously. Interestingly, bleeding is one of the most common early symptoms. Now, patient may present with symptoms of easy bruising, some petechiae on the hands, some bleeding from the nose, some bleeding from the gums, heavy menstruation bleeding, presenting to the gynecologist, sometimes to the dermatologist with petechiae. So these are very mild, innocuous presentation which often gets unnoticed. Some patients may also have thrombocytopenia, and of late we are seeing these kind of thrombocytopenias and everyone runs after dengue. So be careful about thrombocytopenia, and some thrombocytopenia may present to you with bleeding in the CNS system leading to stroke. Intracranial retinal hemorrhages can also present like this. So bleeding is the commonest presentation of pancytopenia. We need to be very careful about it. And symptoms of anemia is the second most common presentation, where lassitude, weakness, shortness of breath, pounding sensation in the ears. These are some of the anemic features which the patient may present to you. It appears to be very, very innocuous, and patient gets overlooked because of these innocuous symptoms. But we need to very carefully look out on the blood pictures. Infection is usually the unusual first symptom in anemia, in the aplastic anemia, which can also get clinically differentiated from agranulocytosis, where infection is the earliest presentation. So, pancytopenia or aplastic anemia rarely presents as infection as the first symptom. Patients uh, also have systemic complaints and rarely have systemic complaints. And if they have systemic complaints or weight loss, you need to look out for other comorbid conditions or other etiologies of pancytopenia. A proper drug history, chemical exposure, preceding viral illness may lead to a clinical diagnosis of the etiology of pancytopenia. A family history of hematological disease or a bleeding abnormality or a pulmonary or liver fibrosis or early hair graying will point to telomeropathies called dyskeratosis congenita. A family history of unusual infection with pancytopenia and warts presents to GATA2 deficiency. So these are some of the clinical features. And physical examination, you'll see these all things like petechiae, ecchymosis, retinal hemorrhages, bleeding from various sites, blood in the stool, weakness, pallor of the skin, mucous membrane, cafe spots, short stature, peculiar nails, leukoplakia, early graying. So these are some of the usual physical findings which you can gather while examining a case of pancytopenia, and this should start your warning bells to ring when you see this, and pancytopenia should come into your mind as one of the differential diagnoses. Remember, lymphadenopathy and splenomegaly are highly atypical of aplastic anemia. So if you are seeing lymphadenopathy, splenomegaly, it is not aplastic anemia. It may be something else other than that. And aplastic anemia could be secondary to the primary disease, secondary to some other diseases like leukemia, lymphomas. No, in our part, visceral leishmaniasis. So lymphadenopathy and splenomegaly are atypical presentations of aplastic anemia. Start looking out for other causes of bone marrow suppression. Now, diagnostic algorithm. So as I already told you, the first and the foremost thing which needs to be done is a CBC and the peripheral smear, which is the initial most evaluation of the blood cell lines. Then we go on for bone marrow examination, assess the cellularity and morphology, and then the etiological categorization as the cause of pancytopenia, the cause, whether it's an aplastic anemia, whether it's a malignant cause of bone marrow failure, whether it's an infectious cause of bone marrow suppression, or it's an autoimmune reaction leading to bone marrow sequestration or failure. So if you see the blood picture, the smear will show large erythrocytes and a paucity of platelets and granulocytes. The mean corpuscular volume is commonly increased. Reticulocytes are absent or few, and lymphocyte numbers may be normal or reduced. The presence of immature myeloid forms in the peripheral smear would suggest leukemia or atypical myelodysplastic syndrome. A nucleated RBC suggests a marrow fibrosis or tumor invasion. Abnormal platelets would suggest either peripheral destruction or a myelodysplastic syndrome. Now, here is that interpretation. If you're seeing a blast, suggests leukemia. If you're seeing a hypersegmented neutrophil, start thinking of megaloblastic anemia. If you're seeing cystocytes, you should look out for Mahas or thrombocytopenic purpuras. Teardrop cells will again lead to a diagnosis of myelofibrosis. Now, the next step is bone marrow examination, and usually the bone marrow is readily aspirated but diluted on smear, and fatty biopsy specimen may on naked eye would appear pale or withdrawn. Usually the bone marrow, you will get some material out of aplastic anemia, and if there is a dry tap, it suggests a fibrosis or a myeloleptosis. In severe aplasia, the smear of the aspirated smear specimen shows only red cells, residual lymphocytes, stromal cells, and the biopsy, which should be more than 1 centimeter in length, is superior for discrimination of cellularity and shows mainly fat under the microscope, with hematopoietic cells occupying less than 25% of the marrow space. So you'll be seeing more fat, less cells, and the ratio would be 25% or less. So cells would occupy less than 25%. And a severe bone marrow failure, you would only see fat. Now, the correlation between marrow cellularity and disease severity is imperfect. So, you cannot very well say that if you are seeing acellular bone marrow, it means a severe disease. Maybe there would be some hot spots where the cell lineages would be more. So, hence, don't assess uh, prognosis based on the bone marrow cellularity in the bone marrow biopsy. It suggests a diagnosis, and further workup has to be done. Residual hematopoietic stem cells should have a normal morphology, except for mildly megaloblastic erythropoiesis, and megakaryocytes are greatly reduced and usually absent. And if you are able to see granulomas, start thinking of an infectious etiology of marrow failure, especially disseminated tuberculosis, which is fairly common in our part of the country. Now, other ancillary studies which can also be done is chromosomal breakage, which would be diagnosing Fanconi's anemia, telomere length, which would be diagnosing the telomeropathies, especially the dyskeratosis congenita. Chromosomal studies of bone marrow could lead to a diagnosis of MDS. Flow cytometry could lead to a diagnosis of PNH. Its serological studies could help us diagnose the Epstein-Barr virus, the HIV, post-hepatitis, aplastic anemia, as I already told you, seronegative. So ancillary studies could go on to suggest the etiological diagnosis. Genomic studies can further diagnose the different causes of other causes of aplastic anemia. Maybe leukemias can be diagnosed, acute myeloid leukemias can be diagnosed by the genomic studies. So diagnosis is usually straightforward based on a combination of pancytopenia and a fatty bone marrow. Remember, aplastic anemia is a disease of young and should be the leading diagnosis in pancytopenic adolescent or young adults. When you are seeing an adult with bone marrow, with pancytopenia, start thinking of secondary causes. The primary diagnosis is usually obvious from either history or physical examination, like a massive spleen, alcoholic cirrhosis, or Kala-Azar, or a history of metastatic cancer or SLE or miliary tuberculosis on chest radiograph. So aplastic anemia in young patient always leads to a diagnosis of bone marrow failure, but in an adult, start thinking of other causes of bone marrow suppression, as I already told you. So this is the diagnosis, and this is how we proceed. So let me give some time to this algorithm. So when you have seen a clinical, you have assessed a patient, uh, followed by a complete hemogram with differential counts, peripheral smear, corrected retic count, RBC indices, and morphology, you make a diagnosis of pancytopenia. What is the diagnostic criteria? The diagnostic criteria is hemoglobin of less than 11 grams per deciliter in males or less than 10 grams per deciliter in females, a total leukocyte count of less than 4,000 per liter, a platelet of less than 150 million. Based on this diagnosis of pancytopenia, we proceed to bone marrow biopsy or a refined biopsy. Now, I already discussed this bone marrow biopsy could be hypocellular, could be cellular. Now, if it is hypocellular, the differentials which should come in our mind is acquired aplastic anemia, constitutional aplastic anemias like dyskeratosis congenita or Fanconi's anemia, paroxysmal nocturnal anemia, leukemic blast cell morphology, bone marrow lymphomas. Now, if you are seeing this hypocellular bone marrow, the differential diagnosis already discussed, the next step would be the assess for the drug exposure, do a viral serology for HIV, HPV, HCV, dengue, parvovirus B90, Vidal test, blood culture, enteric fever, see the LD bodies, and make a diagnosis. Now, vis-a-vis a situation where the bone marrow is cellular, now we can have two types of cellular bone marrow with a diagnosis of pancytopenia, which is a primary bone marrow disease or a secondary to systemic diseases. A primary bone marrow disease would be morphology like dysplastic changes, infiltration by leukemias, lymphomas, and multiple myelomas, myelodysplastic syndrome, or leukemia or lymphomas. These are primary bone marrow disease with cellular bone marrow and pancytopenia. Secondary to systemic diseases, we can have megaloblastic anemia because of vitamin B12 deficiency or folate deficiency, antiparietal cell antibodies, and other tropical screw type of diseases. Immunological causes and causes of hypersplenism like systemic lupus erythematosus, hypersplenism due to cirrhosis of liver or chronic liver disease, overwhelming infections, sarcoidosis. Usual infections which can cause cellular bone marrow and pancytopenia, LD bodies for Kala-azar, bone marrow granulomas because of the tuberculosis. Malaria pigment can be seen if it's overladen with malarial parasite across the body. So this is how we proceed with a diagnostic algorithm of pancytopenia. Do a blood picture, a CBC, a reticulocyte count, make a diagnosis of pancytopenia, do a bone marrow, establish whether it's hypocellular or cellular. If it's hypocellular, start searching for acquired aplastic anemia, constitutional aplastic anemia, PNH, leukemias, lymphomas. And if it's a cellular bone marrow, start thinking of primary bone marrow disease by looking at the bone marrow of dysplastic changes, suggestive of dysplastic myelodysplastic syndrome, leukemias, lymphomas, infiltrations by multiple myeloma cells. Secondary diseases could be Kala-azar, infections like tuberculosis, infections like hypersplenism due to cirrhosis of liver, systemic lupus erythematosus, sarcoidosis. It could also because of it could also be because of bone marrow suppression leading by vitamin B12 or folate deficiency and antiparietal cell antibodies. So this is in short the approach to pancytopenia in adults. Now the problem, there are two big problems. How do we diagnose constitutional aplastic anemia vis-a-vis acquired aplastic anemia from bone marrow? A bone marrow in constitutional aplastic anemia is usually morphologically indistinguishable from aspirate in acquired disease, and the diagnosis can only be suggested by family history, abnormal blood counts since childhood, or the presence of associated, sometimes subtle physical anomalies, as I told you, cafe alert spots, the skeletal thumb, the fibrosis of lung, fibrosis of liver, suggesting of telomeropathies, ribosomopathies, or Fanconi's anemia. Genomic testing is going to help. So history, when you see bone marrow, which could confuse you from a congenital versus acquired, go out for seeing the subtle physical abnormalities, or look out from history and then go for genomic testing. Myelodysplastic syndrome again throws another challenge in the diagnosis of aplastic anemia, and it would be very difficult to distinguish from hypocellular variety of MDS. Now, MDS is favored by finding morphological abnormalities, particularly of the megakaryocytes and myeloid precursor cells, and typical cytogenetic abnormalities, somatic mutations on genomic screening of myeloid neoplasm cells. Yet, still, there remains an unclear boundary between immune aplastic anemia and low-risk MDS, and you need to go for chromosomal studies, especially the 13q and the 20q deletions would suggest myelodysplastic syndrome. So this is all about the diagnostic workup. So what are the prognostic markers? So severe disease is classically defined by the presence of two of the three parameters. When we call a severe aplastic anemia, when the absolute neutrophil count is less than 500 per microliter, or a corrected retic count is less than 1%, or absolute retic count is less than 60,000 per microliters, or a platelet count is less than 20,000. Presence of PNH clone, short telomeres on presentation, and somatically mutated white cells are other poor prognostic markers. So these are some of the poor prognostic markers of aplastic anemia. And how do we treat or how do we manage? Severe acquired aplastic anemia can be cured only by replacement of the absent hematopoietic stem cells by stem cell transplantation, or it can be ameliorated by the suppression of immune system to allow the recovery of the patient's residual bone marrow function. Remember, glucocorticoids are of no value in the treatment of primary therapy of aplastic anemia. So if a drug is causing the aplastic anemia, remove the drug from the system. If an infection is causing, treat the infection as early as aggressively as possible. But if it's acquired aplastic anemia, treat with hematopoietic stem cell transplantation. Hematopoietic stem cell transplantation is the first choice for the young patients with a fully histocompatible sibling donor. For an allogenic transplant from fully matched sibling, the long-term survival rate is almost 90%. The situation is slightly grimmer for adults or late adults because transplant morbidity and mortality are increased because of the chronic graft versus host disease and infections. Nevertheless, transplant should be considered in all patients, irrespective of the age, and if alternative donors are present. HLA typing should be ordered as soon as the diagnosis of aplastic anemia is established in a young child or adult. In transplant candidates, transfusion of blood from family members should be avoided so as to prevent sensitization to the histocompatibility antigens. In general, limited number of blood products preferably do not greatly affect outcome, especially when blood products are depleted of leukocytes. You remove the leukocytes from the blood products and then transfuse. Unfortunately, most patients do not have a suitable sibling donor, and occasionally a full phenotypic match is found within the family. Now, with high resolution matching at HLA, outcomes are similar to those with sibling donors, and although complications are there, but these things are a thing to be taken. Cord blood could also be a source of stem cells, especially for children. Matched unrelated donor transplants are often considered as initial treatment in children and as salvage therapy for adults after failed immunosuppression. And transplantation from an HLA haploidentical family donor is increasingly becoming popular as these donors are almost quickly available. Now, post-transplant cyclophosphamide appears effective in preventing this GVHTs. Now, why we are talking? Because majority of the patients who present themselves for transplant are adults and who have run from pillar to post while searching for treatment. So these are forming the major chunk of presentations in stem cell transplantation centers, and hence devices or science has tried to address to these problems via these things. Now, where immunosuppression is indicated, immunosuppression is indicated where there is no suitable donor, where the age of the patient is advanced, and where the disease is milder variety, less severe neutropenia is there. And the standard regimen is antithymocyte globulin, the ATG, in combination with cyclosporine, and this induces a hematological recovery to the tune of 60 to 70%. Improvement in granulocyte generally is apparent within 2 months of treatment, and early robust hematologic response correlates with a long-term survival. So if there is an early response, think for a long-term survival. Most recovered patients continue to have some degree of bone blood count depression. The MCV remains elevated and the bone marrow cellularity returns toward normal very slowly, if at all. Majority of these patients go on to become cyclosporine dependent, and hence they need chronic cyclosporine for them. Another issues are relapse or failure and clonal evolution in isolated chromosomal abnormalities or the development of MDS is also one of the concerns for immunosuppression therapy. Now we have thrombopoietin mimetic, the L-thrombobac, which is doing wonders in this scheme of things. Thrombopoietin mimetics have shown unexpected activity in refractory disease, producing robust trilineages and usable durable hematological response. Now, the mechanism of action of thrombopoietin mimetics is stimulation of the hematopoietic stem cells, but iron chelation and increased regulatory T cells are also a possible beneficial effect. L-thrombobac added to first-line immunosuppression with horse ATG markedly increases overall and complete response rate to almost 80 to 50%. It is approved by the US FDA for refractory aplastic anemia in combination with horse ATG and cyclosporine in initial therapy. Now, if we start talking of ATG, horse ATG is superior to the rapid APTG, and it is administered through an intravenous infusion and requires hospitalization. Many times there is some immunological reaction because of ATG, and methylprednisolone is used in these situations. Cyclosporine is administered orally at initial high dose with subsequent adjustment according to the blood levels Remember, cyclosporin is a toxic drug, and the important side effects of cyclosporin are nephrotoxicity, hypertension, and seizures. Androgens have also been promoted, but they are not as first line therapy in all the in the immunosuppressive management or drug management of pancytopenia. Supportive care becomes very important, and hand washing, which is the single best method of preventing the spread of infection, remains still a neglected practice. So, teach your patient of hand wash, especially the attendants, while planning for a long term management of pancytopenia. Both platelets and erythrocyte numbers have to be maintained by transfusion. Preferably use single donor platelet transfusion and target a platelet count of more than 10,000 only, because the bleeding at the gut level will start if the platelet is less than 5,000. Menstruation has to be suppressed either by oral estrogens or nasal FSH luteinizing hormone antagonists. Aspirin and other NSAIDs should be minimized or should not be used at all, because it can cause thrombocytopenia and lead to bleedings. Infections have to be managed, and antifungals have changed the way the survival of pancytopenic patients, especially after transplant, have seen. So this is one of the major reason of improvement of the prognosis of pancytopenic patients after post-transplant. RBCs should be transfused to maintain a hemoglobin of more than 7 grams, especially in patients who have cardiac or pulmonary disease, 9 grams. A regimen of 2 units every 2 weeks will replace normal losses in patients without a functioning bone marrow. Even if the blood is not, so bone marrow is not done, you have to transfuse 2 units every 2 weeks. In chronic anemia, iron chelators have to be used like desferrioxamine or desferaxirox if after 50th transfusion to avoid secondary hemochromatosis. So, in nutshell, pancytopenia is a reduction of all three cell lines: red cells, white cells, and platelets, often presenting with fatigue, infections, and bleeding. It can result from bone marrow failure, malignancies, infections, autoimmune diseases, nutritional deficiencies. Initial workup includes history, physical examination, CBC, bone marrow failure to determine the cause. Systemic diagnosis, detailed history, physical examination, lab, bone marrows should be done. A targeted management has to be ensured, and so that we have a successful patient after the treatment. Thank you very much.
Thank you so much, Dr. Das, sir. It was really an exhaustive presentation on approach to aplastic anemia. There are a few questions in chat box, so let me see. Okay. One is how to proceed in patient with pancytopenia, very old individuals who cannot afford bone marrow testing. Okay. Sir, I have already discussed about all the things, how we have to go approach of pancytopenia. If very old individuals, this is not the answer, because if you have to diagnose the original cause of that pancytopenia, and if you are not picking up through the PBF or the CBC, then of course we have to go for a bone marrow testing. Right,
Moreover,
sir?
we must understand that later the
Sir, your
presentation.
voice is not coming.
Hello, hello,
No, 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 not audible.
No,
hello,
sir.
hello.
Audible, sir.
Yes, we must understand that the major cause of bone marrow failure occurs in young patients. The elderly who are presenting with pancytopenia start thinking of secondary causes of bone marrow suppression, especially malignancies and infections. So, if start searching for secondary causes, and if you are able to find secondary causes of bone marrow suppression, treat that. If you're not able to do that, bone marrow biopsy has to be done, and there is no substitute for that. That's what Dr. Daria was talking about.
Yes, sir. Another question in chat box is that will we need to send ANA profile in all cases of pancytopenia with cellular marrow, even if other rheumatological symptoms are absent?
So that is not a universal answer to that. You need to do all tests. At the very outset, you should have an open mind while seeing a patient of pancytopenia. Start looking out for clinical markers suggestive of bone marrow failure. If you're not able to find ANA workup, ANA should be in the workup. That's not a problem, but don't get focused on the autoimmune causes only. You can have drugs. You can have, as I told you, accidental exposure to radiations.
Radiations.
Yes,
So
laboratory
then,
workers, X-ray
so
technicians do have exposure to radiations every day.
yes, definitely, sir. There are n number of causes of pancytopenia. So we have to see the clinical picture along with the symptoms. Okay. So if you think out that it may be because of some connective tissue disorder or some rheumatological problem, then only we should send that. So we have to go by exclusion criteria. So we have to exclude one by one to all other. So in that, if you feel that ANA is important, then only we have to send. Otherwise, no need to send in all patients. All right. Next question is role of L-Trumbopag and Denazole.
I already answered where Eltrombopag is placed. Eltrombopag is placed along with ATG treatment, and it's doing a wonderful response. So it is one of the important drug in immunosuppression when you are planning for immunosuppression. So Eltrombopag is there in the treatment protocol of immunosuppression. Now, androgen or what he was talking, androgen treatment is being tried, but it's not in the usual course of things. So remember, these are drugs which are being tried, but they have not shown much improvement. As of now, the two ways of treatment of pancytopenia is stem cell transplant, hematopoietic stem cell transplant. That is the definite way. And in patients who are not fit for stem cell transplantation, immunosuppression. And amongst the immunosuppression, ATGs, that's antithymocyte globulin and Eltrombopag, along with cyclosporin, has becoming the rule of treatment these days.
Yes, sir. So L-Trumbopag is also being used alone if a patient is having a ITP.
Yes.
So if there is a ITP in cases of acute condition where the bleeding is there, then also you can use the L-Trumbopag. Okay. Oh, very good question. Somebody asked, although pancytopenia is present, then why aplastic anemia called anemia?
Because it
Uh,
has it has hemoglobin values attached to it. So the diagnosis comes with the lineages. So it has all three lineages, and hemoglobin is also known. That's why it's called anemia.
So, okay. So my take on in this question is that you are absolutely correct that it should be nominated or it should be titled as a aplastic pancytopenia. Yes, but the historical value of this aplastic anemia is that primarily they found that it is of a RBC cell lineage and later on involvement of both other the WBC and the platelet. So that is why, yes, of course, it should be a plastic pancytopenia, but because of the historical value, we used to call it as a aplastic anemia.
remember
Next is
remember aplastic anemia, uh, hypoplastic anemia. Uh, these are now called bone marrow failure syndromes.
yes, BMFs. Another question is early warning signs in bone marrow or peripheral blood that precede the development of overt pancytopenia.
I didn't get this question, please.
So, Dr. Neha wants to ask that what are the early warning signs in bone marrow or PBF that precede the development of overt pancytopenia? So
Early.
I don't think so that we can predict by the warning signs in PBF and marrow that
Okay.
that patient will go to the overt pancytopenia or it's only a acute condition.
So Dr. Neha
Like
wants to know. Dr. Neha wants to know, when can we diagnose bone marrow failure even before it's there.
yes,
So that is not possible actually. So unless you have early signs, you will have some symptoms. You will have some peripheral smears which will be showing immaturity. So increase in the MCVs, low cell counts will start showing early, and these could be the early signs. But these are not no early, mild, moderate, and severe. These are classes of different pancytopenias, which I already told you that severe is called when the Hemoglobin is less than 7. The total absolute neutrophil count is less than 500. Platelets are less than 20,000. Retic count is less than 60,000 and 1%. So these are severe symptoms. You just can extrapolate to the milder variant, and these are the places where you can predict a bone marrow failure.
And Dr. Neha, as we know that the mostly causes of this pancytopenia are of acute conditions. So if they are acute, then I don't think so. That more people will go to the overt pancytopenia, because overt pancytopenia will develop over a period of time. So in that case, there is a no warning signs which you can see in the marrow and the PBF, that will go into the overt or not. Another Neha wants to ask, Altamopeg in aplastic anemia is only for thrombocytopenia component or for whole series?
It's a way of, it's a thrombopoietin mimetic, and it's going to act on all the three series. So that's so intriguing about it. Eltropobag was used only for platelet cell lineages, but when it was used for aplastic anemia or pancytopenia patients, it did a magic trick. And I just mentioned that through different pathways, which is still not very well explained, it's going to act on all the three cell lineages. So definitely it was used for platelet counts, but it's showing its usefulness in all three lineages.
Yes. Next is, will we give supportive treatment with B12 and folate in all pancytopenia patient before
No,
and during the definitive? No, I don't think so. Yes, Kedas sir is also agree with me.
no, no.
And another, is it
Yes.
normal to have an immature blast in vitamin B12 deficiency anemia after correction of vitamin B12 and blood transfusion? I don't think so.
It takes some time for the B1 B12 to raise to the to go
No, no,
into
sir.
the.
He's asking particularly for the immature blast.
No, no, that's not possible.
So I don't think that blast will be only seen if there is a your leukemia, something like that. But you will not found the blast cell in the B12 deficiency, and that is also after the correction. No. What are the common solid organ malignancies that will lead to pancytopenia in your practice, sir? Will GI tract malignancy lead to pancytopenia?
Well, all the solid organ transplant, or solid organ tumors which infiltrate to the bone marrow will cause bone marrow suppression. And the commonest cancers which spread to bone marrows are breast, prostate. So these are some of the, and these are what we see in day-to-day practice also. So breast cancers do have bone marrow suppression. Prostate cancers do have bone marrow suppression. Lung cancers, colonic cancers. So all the cancers which migrate or metastasize to bone marrows are going to cause bone marrow suppression. Our
Yes,
practice
sir.
is same. What we are talking about.
How to treat secondary myelophthisis other than treating the cause?
Secondary myelophthisis is uh, caused because of some infection, inflammation, inflammatory diseases. So, treating the cause is the treatment of those diseases, and bone marrow is usually response to that.
Yes, sir. In which cases of ITP will we use Altamopag, sir? First or second acute, or yes, definitely it's we use Altamopag in the acute conditions only. In chronic, no need to give this Altamopag drug. And Neha is still confused. She is asking anemia is diagnosed at the time of discovery at first. That's why name aplastic anemia or something else. Not understood. Even although I don't know why, but as the since ages we are reading this as a aplastic anemia. So Neha, I'm also don't know the exact cause. Okay, Das sir.
Anemia is diagnosed at the time of discovery at first. That's why name aplastic anemia. Or something. I didn't get the question even. What
The
is the
question
twist of it?
again, he wants ki that aplastic pancytopenia, why it should not be? Why it is aplastic anemia? There are
Anemia.
all
Why
three
the word
anemias are.
anemia is there? No, why the word
Yeah, yeah,
anemia is there?
yeah.
So
Yes.
the anemia is there because it affects the RBCs also. And Dr. Daria was uh, very rightly informed that it was first thought of as anemia, and when it was discovered in detail,
Later on.
it went on to establish that all the three cell lineages were there. The name continued, and that's why it's called aplastic anemia. And I told you that it's no more aplastic anemia. All these are now bone marrow failure syndromes.
Yes. And the last one is ITP. Will we need to give steroids lifelong, sir, or can stop after counts improved? I don't think so, sir. I am not in favor of that lifelong steroids in the case of chronic ITP.
Steroids are of late in disrepute as far as ITP treatment is concerned. We have other drugs of which eltrombopag is there. So steroids, long-term steroids, definitely no.
Sir, patient present to us with megaloblastic anemia. Further workup revealed B12 deficiency, and after transplant B12 therapy initiation, we are getting blast in subsequent CBC. So, is it normal to get blast cell? I don't think so. It is normal.
Uh, uh, this could be a response to the vitamin B12 that we are giving, and we need to follow this patient for the first next 3 months before we go on to label it as something else which you are trying to refer as. We need to be slightly careful in making a diagnosis of malignancies in these situations. Let the cell adjust the maturation factor of vitamin B12, and then it will start showing the correct picture.
So, particular word blast is something different, but like normoblast, erythroblast, they are the normal things. But if you are saying particular blast, it is something wrong.
Yes. So, but we need to be slightly careful, and we need to
Yes.
follow this patient for the next 3 months with a bone marrow biopsy. Then we can label it.
Thank you so much, sir. It's almost quarter to 2 hours we are here and everybody is listening to you. Hats
Thank
off to
you.
you, sir. Yeah,
Thank you
your
very much.
zeal to
Thanks
teach.
to all students and the young fresh graduates that we are in. Thank you, Dr. Daria, for a wonderfully held program today. This program is being recorded, and as told by Dr. Kamlesh Tiwari, Dean of ICP, you'd be getting question answers at the end of the session for which you have to sit in for an exam, and then you'll get the certificates. Attendance is a mandatory, and you need to ensure your attendance in every class. So good luck to everyone for the next week. We'll be there on next Tuesday with another session of short certificate course, clinical hematology. Thank you, Dr. Daria. Thanks,
Thank you
Dr.
so much,
Tiwari.
sir. Thank you, everybody,
Thank you, Dr. Sudhir
for
Mehta,
joining us.
for giving us this
Yeah.
opportunity.
Thank you,
Bye
sir.
bye. Bye bye.
Okay, bye bye.